Hey, good evening, advocates. Welcome back. I am so super excited about this conversation we're going to have tonight, and really excited to have a guest who not only is incredibly authoritative, but honest to God, one of the nicest people I know, and one of the best consultants I've ever worked with. And so I'll be bringing Fred in momentarily, but I will tell you that. Um, the topic we're going to discuss tonight is something that became an element of the Take Care of Maya trial, and that's culture. And it's one of those things that, there was a famous quote by Justice Brandeis in the Supreme Court back in the 20s. And he said, "I don't know how to define pornography, but I know it when I see it." And culture is very much the same way. Culture is really the atmosphere that you are in. It's the connectedness of the teams, and in healthcare, there may not be a bigger, more important example of teamwork. So if the culture is bad, then the players on the field don't necessarily play all that well together. And that became very, very apparent as an influencer to how Maya and other kids like her fell through holes in the safety net. So, if you'll remember, when we started, when Judge Carroll started talking about bringing the immediate jeopardy into the testimony, one of the things that he talked about when he was demanding that the hospital attorneys produce the IJ and all the papers related to it. If you remember, I believe his quote was, "If it has even a scintilla of odor related to the IJ, I want it provided to plaintiff's attorney." And he talked about how far back do we go? 3 years, which is the length of how long a Joint Commission survey really kind of frames around 3 years of work at a time. But if you'll remember, Judge Carroll talked about going back to 2011 or 2012 because that's when Dr. Jonathan Ellen became the president of All Children's Hospital after the takeover by Johns Hopkins. And as he articulated, and I'm paraphrasing now, as he articulated, culture starts at the top. And if you recall, in December of 2018, Dr. Ellen stepped down. And in fact, there was an article published in the Tampa Bay Times on December 11, 2018, and this is part of the Heartbroken series for which Kathleen McGrory, sorry, and Neil Beatty um, were considered for a Pulitzer Prize. Their series Heartbroken was at the top of the heap in terms of investigative journalism. And the article on December 11, 2018 talked about top executives resigning, and it was Dr. Jonathan Ellen, who was president of the hospital, Jackie Crane, who was at that time the chief strategy officer, but also, as described in the article, was the lead executive over risk. And remember that when we looked at the org chart from the time that Maya was a patient, she was the senior counsel, and risk management department reported up to her. And we talked about the gap in that communication. But there were, in that same article, Ms. McGrory and Mr. Beatty quoted that there were at least 8 employees who warned supervisors about problems, but in their writings in this Heartbroken series, McGrory and Beatty described those warnings as, quote, disregarded. And that is a problem of culture and communication. So when our local member of Congress, Kathy Castor, talked with the CEO of Johns Hopkins Medicine up in Baltimore, Dr. Paul Rothman. Kathy Castor talked about her deep concern about the problems at All Children's. And Dr. Rothman, it was attributed to Dr. Rothman that he was, quote, unaware that employees had raised concerns. So again, that's the disconnect that we talked about in the testimony about the board not knowing what's going on and this reporting structure that the org chart required, and where Jackie Crane reported directly to Johns Hopkins in Baltimore. Clearly, the communication was not taking place. And if you remember that after Kevin Sowers came in as the interim CEO after Jonathan Ellen stepped down, they prepared talking points for him to address the board. And one of them specifically addressed, quote, a culture of retaliation and retribution, right? So that's a problem. As I said when I was on the stand, if you spoke up, you did so at your great personal risk, right? So that's unhealthy. And that's where my friend and our guest tonight, Fred Neis, is really deep. And I think you're really going to enjoy meeting him. So let's bring him in now. Fred Neis, welcome to the channel, and welcome. I'm sure all the advocates would love to say hello.
And I will say hello back. That was an amazing tee up there and extremely powerful. So thanks, Joe, for that. I'm waiting for this Fred Neis to show up. That's the expert. I'll be waiting for the rest of the advocates.
Your mom wrote that intro for me.
That's right. That's right. Exactly. I've used an alias as well in some of the questions that have popped up on your feed. So.
Fair enough. Hey, so as you saw from the post in the community page about submit your questions, I did talk about your credibility, your authority, talking about culture. But why don't we start by if you would give the group a background about who you are and why they should listen to you.
Sure. I hope that I'm engaging enough that everybody wishes to at least listen for the remaining, 52 minutes or so. I'm really excited to be here, and I truly mean that. So a little bit about me. First of all, I live in Kansas City. So hello from the reigning AFC champions, Kansas City Chiefs area. We're excited for Sunday, underdog or not. I'm Fred Neis. I am a registered nurse, and I've been in the healthcare field for over 30 years now. And, I started my journey really kind of as an EMT and a firefighter, worked my way through college, graduated as a registered nurse and a paramedic as well, and as a firefighter. And over the years, I've kind of done what one might kind of stereotype if you kind of put me in a central casting location and ask me, what do I look like? I did emergency services, emergency departments, trauma centers, life flight helicopter, and eventually moved into some leadership roles within a couple of academic medical centers. And then really didn't know what I wanted to do and got kind of curious and ended up calling a friend at the advisory board company and said, I don't know all that you do there. You're always happy. You have seemingly an excitement to you, and you do great work. And I would love to learn more about what you do. And if you have a place for a guy like me, I'd love to entertain the idea. And that's actually for the benefit of the advocates on this podcast. That's how Joe and I actually met, was at the advisory company. And we spent a number of years together working as a partnership on a lot of optimization projects and work and culture and technology integration and quality and cost, and just really had a great time. And in fact, there was a podcast just a couple of days ago that had Robert Musselwhite on it, as a matter of fact, that spoke to the culture there and how truly unique it was, and that it unlocked a corporate performance, revenue wise, person wise, and developed us as people. it was amazingly unique. And I wish if we could have bottled that up and sold it, the world would be
True.
much better, much different and better place. I mean, it was just such a great experience. And then, I've moved on to a couple of different roles and continued to be curious and challenge myself. And now I sit with colleagues at Korn Ferry. Most people know us as a search firm or the sponsors of a PGA tournament. But one of the things that we really kind of pride ourselves on is we do all things people related. So as we think about it from regardless of the industry, we're invested in how to optimize and pull out the best in all the people. So, without further ado, let's jump into it. I appreciate to determine that I am an expert is not upon me. It will be upon your advocates by the end of this to decide, is this guy for real? And is he really an expert in this? So yeah, let's dive in.
Well, you're being teed up as an expert. You've got about an hour to prove yourself, right? So, but this is a very friendly, very motivated, very caring, and very altruistic group. So don't worry, there aren't too many daggers out there, but I'm looking forward to this hour. And just as we're getting started, I just want to point out, I just want to thank Charlie Lynn for once again gifting memberships. That's incredibly generous of you, Charlie Lynn. Thank you so much. Fred, I think that there were some really good questions raised by this audience. And by the way, I think you have really tapped into the Kansas City Chiefs fans. I'm seeing a lot of Go Chiefs in the chatter. Yeah. So, I think that there's a lot of folks, including SN Gray 11. How can we advocate for ourselves and our loved ones when we encounter a negative healthcare environment? That's really going to be probably the most pressing question. But before we get to answering that, why don't you describe culture and give us your insight about how a hospital even develops a culture?
Yeah, no, thanks. I appreciate that. I thought you were swinging for the fences and giving me a tough question, and then this would be a progressive test. And if
just a preview,
questions would get harder and harder as we went. So no, I appreciate you backing up a little bit and giving me the softball side of it. I think culture underpins from a healthcare perspective, and I'll just confine a lot of my conversations to the healthcare space. Though realizing that the culture of an individual and a culture within a healthcare space is directly impacted and affected by all of our outside experiences too. So each one of us is a nurse, a physician, a phlebotomist, an occupational therapist, pharmacist, an employee within the cafeteria staff, we're all, genuinely affected by the outside forces as well. But as I think about culture as a concept, it really is the kind of the amalgamation of social behaviors, the institutions we work in, the norms within our societies, laws, beliefs, and our customs, and kind of how we grew up. And it's also things that we experience and that we see. So within a healthcare space, it is kind of unique in a number of regards, one of which is as a nurse coming in, as a new grad, I learned the culture of that organization in a lot. That was an involuntary laugh, Joe. Can't control it. It happens today, right? Like we get into those facilities and those hospitals, and we learn from the individuals around us. And to your kind of opening remarks around culture starts at the top. It's the behaviors and the actions that then we mimic at the staff nurse or staff physician level, because that's what we see. And so we absorb that, and without real formal training and education and, the ability to have a true kind of unified perspective and set of expectations on behavior and consumer services, it really just sets the tone all the way through. I talk about this one a lot around culture, and the way that I learned some of it, even as I moved into leadership positions, was I was a charge nurse on a Friday. by Monday morning, I was titled formally as a nurse manager of a department. And Saturday and Sunday were not orientation days. And so a lot of what I translated into my early leadership days was a result of seeing my previous nurse managers and directors and how they acted and behaved. And, good news, there's a lot of good elements to it. On the flip side, though, there were things I should have probably done differently. So, culture is built over time, and it's built from typically the top down. And in order to change a culture, just in this exact case that you referenced at the outset with Maya, it typically takes something that's a critical incident that's radical and shakes the organization to its foundation, or it's a change in leadership at the top who then come in and say, we've got to do this differently, and this is what I'm proposing we do differently. So that's
and unfortunately, as K-Rob experienced, come on, you can do this, Joe. Sorry,
I know you can, Joe.
Yeah. K-Rob, where are you? Oh no, K-Rob came up with a great quote in a super chat. Where are you, man? Sorry, K-Rob, I'm looking for you, buddy. But he talked about being in the ER and being misdiagnosed. Here we go. I went to the ER with pain in my abdomen, no kidney stones, sent me home. I asked about the appendix. They told me I had a gold standard test. The report could not image the appendix. And then I'm told me to go over to the hospital. Now the appendix was almost burst. The doctor's shift was over and the medical director backed him up. In a situation like that, where K-Rob knew something else was going on, it wasn't nothing. What do you do in that situation, Fred?
Yeah, I mean, we can take this in so many ways, right? Like we could probably just on that scenario alone from K-Rod, we could take that in so many directions. We'd fill the rest of this hour. It's unfortunate, and I wish I could put a stake in the ground right now and say, oh my gosh, I'm so sorry. That's such a unique situation. It's not a unique situation. And we know that from the research that medical mistakes and errors or lapses in care happen all the time. And if we back that up and start to really look at the root causes of it, a lot of it's still underpinned by culture and the way we the team and the way we interact with the individual or the patient. And all the ways that we may even come in biased with the patient as well. And K-Rob brings up some really good elements in that story around, you came into the emergency department, you invited us as caregivers into one of the most chaotic and critical moments of your life, and we seemingly failed you. And yet we were invited into, and you trust us with that moment in time to do all the right things. And I think one of the things that years ago we've seen some research, and it's rinse and repeat on the research coming out. And I would imagine K-Rob is going to be in the same position and would say the same thing. There have been questions to patients who come out of emergency departments and to say, tell us about your experience in the emergency department and what did you expect out of your visit? And one of the research graphs is the scattergram of the various elements of why someone came to the emergency department and really what do they expect out of the visit. And two things were really kind of pulled out of there that I think would stun most of us. Number one, there are really two things overwhelmingly that individual wanted, and K-Rob's probably got both of these. He wanted to see a physician or a provider, nurse practitioner quickly, and whether he was admitted or not, K-Rob wanted to be in that department as little time as possible. Like, we all don't really want to be in a place like that. We don't feel good. We'd like to go home. We really want the clinicians and the team to diagnose us, help us get a plan of care together, and then potentially be on our way wherever that needs to go. I think strikingly, though, in that body of research is the fact that nowhere in this did a patient respond I wanted to have good clinical care and the right diagnosis. Like inherently, all of us go and seek care, whether it's in the emergency department or it's in a clinic, or it's to go have a baby. We
Yeah.
expect exceptional clinical care. And really what we're asking for is the cultural underpinning of that, of being treated well and being treated like we would want to treat ourselves and we would want to
Yep.
treat our loved ones. And mistakes get made. Like we're all human and mistakes truly get made. And I personally was involved in one 25 years ago that resulted in an individual who eventually died. And we all make mistakes. It's how we respond to those mistakes that really can help set the tone. Optimally, we don't want to make mistakes, and optimally, we want to be a high performing team, and we want to have, exceptional customer service, and we want to just knock it out of the park with the diagnosis. But it also says, if I tease a little bit more out of that story just a moment ago, is the clinicians didn't listen to the patient.
Hmm.
And as you know, as an OB, and I know I still work clinically. I work for a fire department a couple of shifts a month. I had a physician say this once to me years ago, and I think it's so true. If you just listen to the patient long enough, they're going to tell you what's wrong with them. If
That's
you don't,
right.
we don't have to do all these fancy tests. If we
Yeah.
just listen to that individual, they're going to tell us. And it
Yeah.
sounds like a little bit of that happened there. Like, hey, what about the appendix? And instead of having a culture of engaging the individual, the patient who's seeking care, or the family members in, okay, let's talk about this a little bit. And let's kind of look at the research and let's look at the clinical perspective and picture that we have here and take it into totality. It sounds like the doctor may have, I'm diagnosing here a little bit, but went down a road and maybe didn't listen to, well, what is this patient saying? And how do I involve the patient a little bit more in this, in the decision making? And then once a mistake is identified and made, it's the how do we say we're sorry? And not just with words, but also with actions.
Yeah, and that's one of the things that Lorna Lee asked in one of the questions through the community pages. Why is it so difficult for not just physicians but really all members of the care staff to just simply say I'm sorry?
Yeah, yeah. There's a whole host of reasons. Some of them probably just embedded in some human nature. But and then aside from that, for years and years historically, there was, I think, a common perception and probably to some degree a realistic fear by the caregivers that taking that moment and being that vulnerable and having that moment of saying I'm sorry immediately expose them to the liability and the malpractice that potentially would come with that. Because then you've had to admit that there's been a mistake and the patient's probably angry at that, particularly at that moment. The family may be angry. And so one of the ways to get back, if you will, is to sue. And I think that became scary for organizations and hospitals, and physicians as well. And I think that was part of the culture for a number of years. There was also, I think, if I continue to indict us a little bit, there was this sense of we didn't really make that mistake. Like we can tell you why we didn't make that mistake. Ultimately, though, and for the really high performing organizations and the high performing physicians and clinicians out there, what we find time and time again in the research is to say you're sorry is extremely powerful. And to say you're sorry when you've identified that you've made a mistake really does go a long way with the patients and the families. And eventually, and
Yeah.
relatively quickly, as they go through kind of the 5 stages of grief with you, they start to realize like we're all kind of human. We all kind of make the mistake. Now, that's not to say that, it should excuse us from having to make some reparations and actually not just with words, but with actions. How do we help you? Right. So if we make a mistake, how do we make sure you're not paying for that mistake financially? And how do we make you as whole as possible?
And Fred, I just want to raise the point, and I know you and I both agree on this because we've had this conversation before.
Hmm.
Even when you do everything right, sometimes you don't get the outcome that
Yeah.
was expected, right? And you can still express um, express that you're disappointed with the outcome. I
Mhm.
wish that we had a better, so I'm sorry we didn't get a better outcome,
Mhm.
you know, and I don't know what the nursing literature says, but the medical literature is very consistent and strong that when you do in fact say I'm sorry, it lowers the risk of
Mhm.
litigation.
That's right. 100%. It shows it in the hospitals as well. And I think,
Yeah,
I saying we're sorry, I think one of the things, and even in the scenario you and I are talking about and wholly agree on, it goes back to the culture piece. If I'm
yeah,
in a culture where maybe I'd set it up that way too, when in just talking to the patient well beforehand, hey, look, there are three ways that this thing could go. And
yeah,
we're going down this road, but I just want to give you kind of a sense as to here are the three ways that your disease may progress or this
yeah,
injury may get worse or better. We're hoping for the best. We're planning for the best, and hope is not a plan. So we're planning for the best, and we're going to
yeah,
do our level best. And I got this exceptional team. And I think, one of the things that I harken back to the advisory board. I fall back a lot on the advisory board because it was, at least personally, so good for me.
yeah.
But one of the values that we had there was the power of language, right?
Hmm.
How do we harness the power of language within a best culture to
Yeah,
exude that? And I was reminded of a fun story about the power of language and how things can be even misconceived. Back in the day where you and I might be getting off shift and, headed out the door, and, man, it was one of those shifts and we were busy, busy, busy. It was, the doors were coming off and, the windows were breaking. It was just crazy. And whatever unit we were working in. And as we're walking out, we say to the incoming shift, man, you don't want to go in there. Oncoming shift, that means, wow, it's busy in there. This is going to be a banger of a shift we're getting into. But I'm
yeah,
walking in. I'm part of the team. I'm here. That's our mission. If a patient or a family member hears that, what's their perception of what they've just
that's
heard?
right.
Whoa,
That's
is that
right.
dangerous in there? Are people
Yeah,
like are people having bad outcomes because things are bad in there? So we have to constantly think about the power of language and the force of ideas and how we
for
use
sure.
words to communicate. And that's true for the
Yeah,
patients too. Like, how do we use those words well in advance of having an unexpected or an unfortunate outcome to plan for that, but prepare ourselves, the patient, as a team for what's in front of us.
it's interesting. The power of language was one of those pillars of the culture at the advisory board that I carried with me through the rest of my career. And
Mhm.
I used to routinely meet with the new doctors, and I would talk about that words matter. And I would give a very close to home example. I would talk about how simply saying "I'm sorry" can
Mhm.
be heard of very different ways.
Mhm.
You have a young son. My kids are older, but when they were little, yeah, believe it or not, my daughter and my son got into fights. Go figure.
Mhm.
And after we would pull them apart, my wife and I would frequently ask them to apologize to one another. And you know how that a 3-year-old and a 5-year-old are going to apologize. They're going to cross their arms, going to turn their back, and they're going to say sorry.
Mhm.
Well, Fred, I don't know about you, but if I ever tried that kind of an apology with my wife, I'm
Mhm.
sleeping on the couch, right? I'm not
If
getting
you're
anywhere
lucky.
near it.
Yeah.
So you may be saying I'm sorry, but the
Mhm.
way you say it may
Mhm.
not come across the way you want it to, right? And
Mhm.
it's interesting because I had a patient who really made it crystal clear for me. She said, I need three things. She said, I need you to fix what is bothering me. I need you to keep me safe. And if it's
Mhm.
not too much trouble, could you be nice to me? And in reality, that's all patients are really looking for
Right.
is take
Mhm.
care of my problem, keep me safe, and
Mhm.
be nice. It's interesting. One of my moderators, Gothic Brina, um, she has rheumatoid arthritis, and at age 13, they put her on painkillers. Right. So again, there are times when you're in a hurry, trying to get the patient moved out. But there's a situation where, she really she needed somebody to speak up for her. And
Yeah.
at 13, can you really count on her to do it on her own? But
Mm-hmm.
that's where I have always asked my staffs, and especially the nurses, because they have more contact than the doctors. I need you to be advocates, right? And that's what I'm asking this audience to do, is to advocate for one another, advocate for their loved ones, advocate for themselves, speak up. And over the course of the next several days, weeks, months, we're going to have more and more conversations, Fred, starting tonight, around how do you speak up? How do you effectively advocate for yourself? So it is a big need that this group is very, very familiar with, and incredibly candid in discussing.
Yeah.
K-Rob also let us know that he's a chronic pain patient. And so, from your time in the ER, chronic pain patients have a very difficult time getting believed. It's hard to establish credibility. There's a tendency where we kind of pigeonhole them as drug seeking until proven otherwise. And what I've heard over and over from this group is that that ain't necessarily so.
Wow.
Headaches, squid pro quo. One of my favorite names online, by the way.
Yeah.
But headaches, pain, bilateral numbness in all limbs. Neuro didn't want imaging. Filed a complaint with a patient advocate. Wow, 7.5 millimeter Chiari malformation with 50. Wow. That's what I'm talking about. This group shares the misadventures that they've been through, and you can sense the frustration that Squid Pro Quo had from that experience. Rob, they will charge you twice, even if it's in 12 hours apart. In reality, if most tests, if there's not at least 24 hours in between, they may charge you, but your insurance is not going to pay for it in most cases. Just so you know. Beck Edwards, thank you for your super chat. I trust doctors that say, I don't know, or admit their mistakes. And that goes to your point, Fred, the credibility and the trust that you build. Somebody had mentioned in one of the comments that trust is very easy to lose and very quick, very slow to be built back up.
Right.
Nancy D, I don't know that I'm going to agree with you on this one. Fred, I'd like you to weigh in. Hospitals dictate to doctors, and I would argue to nurses, what to do. And you only have so much time per patient. Everything is about money. I agree with the fast pace. I don't know that the hospitals dictate what caregivers do. I think we bring a lot of ourselves into the job. Agree, disagree?
Agree and disagree. How about that? I'll split the difference with you as a consultant. Well, Joe, it depends.
It depends, right? Well, there you go. There you go.
No, I think, healthcare is such a crossroads right now. And a lot of it's pretty tenuous because there's these tensions now across the continuum. And I think, honestly, sometimes we've lost our way in terms of, at the center of all of this still needs to be the patient or the person receiving the care. And I think we have, in fact, lost our way. So to some degree, I would say that there are physicians who probably feel this way, and in some ways probably are being told what to do, not necessarily by the hospital per se, but for some outside forces, like the insurance companies and the payers generally. Like, we're starting to put, there's a lot of downward pressure being applied to hospitals and to physicians around how to get costs under control.
Yeah.
There's a lot of that. So there is some of that. I do think, though, that the high-performing physicians and the high-performing nurses and the high-performing people who work within hospitals, I think they still have the ability to make decisions. And I will often say nothing is a substitute for good clinical judgment. So as much as like I might be told, Fred, you got to start an IV on this chest pain because that's what it says in my protocols on the ambulance and you got to go forward. At some point, if I have the conversation with the patient and I understand enough about what's on my differential to make those decisions, I might not start an IV on that particular patient. And I might, it's not that I'm taking chances or risks or trying to give bad care. To your point earlier, it's I'm trying to make the very best decision for the patient at that time to give them the best care possible. Nancy D's comment about everything is about money. As a nurse, I got to tell you, not a single business class did I have in my undergraduate program. Not a single one. I couldn't even tell you in my early years how my paycheck got generated, other than it showed up every other Friday with great consistency. And that is a bit of an issue that I think we've got to bring caregivers, because we all care. Like the DNA of a physician, a nurse, a caregiver, CNA, that DNA is baked and steeped in the idea of caring for someone. However, I think sometimes it would be good if we had a better understanding of how revenue's generated and the funds flow and where that money comes from. Because, I could go way off tangent here, go completely off script and, use all kinds of conversation around money and funds flow and how the premium dollar works. But let's get us back into kind of the culture piece of it. Culture drives kind of a multiple lanes and kind of quickly skimming the conversations as they go by. There's the clinical care conversations around culture. There's the customer service aspects of culture. There's the billing and operational and back office cultural pieces. Like, the conversation or the discussion just a moment ago about how being charged twice within 12 hours and getting a bill for it. And I just got a bill a couple months ago for a colonoscopy, and I was confused. I got 35 years of pretty good experience, and I had to call financial services at the health system to have them step me through it. Like, we can't have that anymore. I'm an alleged expert. We can't have that I can't even decipher it, and I have the decoder ring. So, there are multiple lanes that we got to get through to really bring culture back and make it part of our embedded DNA in our bloodstream to help patients, whether, again, it's clinicians or the back office staff on the revenue and financial side, or the people in therapies, or even our handoffs. I use the emergency department because that's what I'm most familiar with, or the ICU. But how do I hand off care to my colleagues, whether the next shift or the next iteration of care or the next care setting or the next physician to care for them? We got to get better at all of this.
Fred, let me bring up a phrase that you and I are very, very, very familiar with that is exactly on point about handoffs in the emergency room and other situations.
Okay.
What is the truism about nurses and new nurses? Nurses eat their young.
I think I know where you're going with this, but really what I'd like to say is if anybody has missed it, let me just reshare. Nurses are the most trusted profession in the United States over the last 2 decades. But I don't think that's really where you're going. I think where you're going is we wanted it for everyone of your advocates, like we wanted to bring this up and acknowledge this. There's still an eat your young mentality within our culture, just within the nurses. I think, we still expect the new nurses coming out of the nursing training programs to work hard, keep their nose down, do as they're told, put in their time, all of those things. And yet we unfortunately do that to the detriment of the workforce themselves. And we truly eat our young, and it's 20% of all new first-year graduate nurses are looking to get out of the profession. And I won't say
in the first year.
In the first year, and I won't say
1 out of 5. That's
nurses
amazing.
Upon nurses and lateral violence, if you will, to really kind of escalate the language. But I won't say that that's solely the reason that 20% or a fifth of the workforce wants to leave after their first year. There's a whole host of other reasons, and it spans kind of a cadre of reasons. But holy cow, that also indicates the burnout. That the culture and the pressures that are placed on them, the emotional toll. Now, granted, we're coming out of a pandemic where all individuals in healthcare were absolutely worked, like really worked hard. And psychologically, many of them were hurt, and we got to take care of them. We got to figure that out. And then, I do want to say too, that there's this feeling of unsafe that I think comes with the job. Some of it is, mitigated through risk management. And I don't mean risk management with lawyers, but we all take risks. When I step onto an ambulance, I take some physical risks, but we try to minimize those as best as possible. But then there are the other risks too that the nurses are feeling. And, I think, it was borne out. I saw an article this morning that was published on the Nursing Beat. And the Nursing Beat mentioned an article that says, I think it's 86% of all nurses are reporting right now that they've been subject to some degree of violence, whether, through nurse to nurse, or through patient upon nurse, family upon nurse, or, public upon nurse. So, there is some inherent fear that comes with being a nurse. So I think it's a constellation of things, but I want to go back to that truism of eat our young. Like, it starts with us. Like, we got to look in the mirror and say, yeah, we've got to take care of all of this. I don't want to minimize all of those aspects, but it does start with us taking care of each other.
So, and Fred, that's I close each show by challenging everyone to take care of themselves so that we can take care of others. And I think that is an important part of culture. I want to bring up two comments about culture gone bad, but then I'd like to talk about your experience, not only personally in your work experience, but also your consulting experience of places that get culture right. And how much safer that is for patients. Here's a story of not getting it right. Dental hygienist here, corgis and horses. Thank you for your super chat. Dental hygienist here went to the ER for abdominal pain, CT and internal ultrasound, no diagnosis, 3 rounds of morphine in 12 hours. Doctor came in and said, so you're really here for the drugs.
Wow.
Checked out AMA, passed a kidney stone. And I just want to point out, as an obstetrician, as a male, and as an obstetrician gynecologist, I have long been told that passing a kidney stone is the closest that my half has ever experienced at childbirth. But
That's
that just makes your head explode. And then horse welfare. I'm the individual who was ignored by an ER doctor when I had cauda equina syndrome. Wow. How should a patient like corgis and horses who had a kidney stone, how should a patient like horse welfare navigate advocating for emergency medical care when every hour you're ignored is critical to the prognosis and the outcome?
Yeah. I mean, I think
thoughts about that. And then let's talk about where we get it right. Okay.
Yeah. Let's talk about the fun stuff. Yeah. Where we actually,
but let's help address this too.
Totally fair. I'll take your cues. I serve at the pleasure of Joe tonight.
That's a first.
At least for 17 more minutes. Yeah.
Hey, I'm just letting the crew know. He used to make me carry his briefcase in and out of the hospitals we were working at.
The nurse used to ask the doctor, can you schedule this for me? Can you take a note? Exactly. I think the examples in the emergency department are a little different than how I might frame up advocacy for oneself in a non-acute, in a non-emergent setting. Like in an emergency, when time truly is so critical, there's probably a different pathway that, I would advocate, pun intended, I would encourage individuals to take. And there's some practical steps. First off, if we back up just a little bit, to the decision to come to the emergency department is one that not only critical, but it's scary to have to think that as an individual, I think I have a serious enough illness or injury that I need emergency care. Like, people tend to not take that too lightly themselves than when they come to an emergency department. And the choice of an emergency department has, a variety of attributes associated with it in terms of easy access, the brand, all those types of things. Yeah. And then once you get in there, if many folks they only go to an emergency department once or twice in their lives, maybe half a dozen times. And if you have small children, yeah, we tend to go.
Yeah.
Yeah. We're pretty used to. Yeah, we're pretty used to it. But to advocate for yourself, it is part of that communication piece early on. And I think that was expressed in one of the other stories just a few minutes ago, where K-Rob was telling the story of, hey, I'm having abdominal pain and this doesn't feel right. And what about what about my appendix? And so it's being able to express yourself early on in the visit with the clinicians with as much detail as possible to really kind of set the stage for those clinicians.
Yeah.
On the clinical side, though, it's incumbent upon us to listen. And if you're not feeling like we're listening, it's time to potentially engage other colleagues or other people in the emergency department. So, from a hierarchy standpoint, again, time is of the essence, but you can often ask for, I'd like to speak to the charge nurse. And the charge nurse has got to be equipped, and this is on the healthcare executives to teach this culture and teach this set of skills and competencies. But the charge nurse should be the first one that you would want to engage, not the physician, because often this is around the service and potentially some of the quality issues as well. But sometimes it's really just about the cultural pieces of it. And the charge nurse is responsible for overseeing the operational components day to day and in the immediate. Then it becomes a real crazy set of variables. If you're there at 3 o'clock in the afternoon, if you need to continue to escalate, you might want to ask for if there's a senior physician on. There may or may not be, but you can also ask for the director of nursing or administration. If it's the middle of the night, you're probably going to get the night supervisor if you have to escalate that way. You can always ask for clergy, especially in some of the more religiously affiliated hospitals. They'll have clergy physically on staff within the organization, and they can act as a nice mediator to some of this as well. And then, if you have to take, once you get out of that emergency situation and you've had some time to reflect, there are certainly other ways to try and get, your not only your point of view and perspective across, because that's, ultimately what drives, at the end of the day, your individual perspective of the kind of care and the kind of quality and the kind of customer service you got drives our market share as a health system and as you're the driver. We're in the service industry at a baseline. And so if we're not performing well, reporting that to the risk management department, reporting that to the ombudsman office, and then there are certainly what I would consider more nuclear options. But, in the case that you've showcased, time and time again with this podcast around Maya, like there needed to be some real serious escalations. And there were obviously some very serious escalations, but then there were some places where I think ultimately there were some gaps in the process. People didn't probably honestly react as the way they should have to those moments for, a variety of reasons, but yeah.
But I think the point that you raise is really important, Fred, and that is that everybody's got a boss, right? And Tip ONeal, when he was Speaker of the House back in the '80s, I'm showing my age, but
I'm sorry, who was that?
I
don't remember Tip ONeal. Who was that?
Thomas P. ONeal. Tip ONeal famously said that all politics is local. So I agree with you. Start locally. Start with. May I speak with the charge nurse? Charge nurses are incredibly powerful within their district, if you will, in the ER, on 3 North, wherever you are. The charge nurse can be a tremendous ally. And I will tell you, and we were speaking briefly about this earlier, nurses can be incredibly effective advocates. I know that when I was in practice, I had nurses that taught me how to start IVs when I was a medical student. I had nurses that let me sleep when the patient was ready to start pushing, but it was a first-time mom who was going to be pushing for 2 hours, and I had already delivered 2 other babies. So nurses have a lot of latitude in how they can help. But I agree with you that if you're not getting the answers with your local care team, talk with the charge nurse first, talk with that nursing supervisor, who is kind of the charge nurse for all of the units. And then in the executive suite, there's a chief nursing officer who ultimately is accountable to the executive team, the board, the system. I will tell you that I have, and if the issue is with a physician, I agree. It's more difficult. Try to speak to whoever their boss is. If it's in the emergency room, there usually is a director, medical director in the ER. But you know what, Fred, and I've shared this with the audience before. I have had patients, when I was a facility chief medical officer, I had patients come to the administrative suite and want to talk to somebody. Usually they ask for the CEO. Typically, I would try to get involved because, again, I couldn't do anything because I didn't treat patients, but I had people.
That's
and
right.
I knew who I could get them in touch with. So there's always somebody more that you can escalate to. So I know it's very Karen to ask for a manager, but there's a reason why you do it. It works. So speak up. Don't be afraid.
I wholly agree. And, the perception of Karen aside, like we're in a, not necessarily hyperbole, we're in a life and death situation, particularly in the emergency department. Like, it's time to advocate for yourself. Now, there are some ways that you could advocate for yourself in the wrong way, threaten violence, start yelling, swearing, those types of things. But as long as you're pretty well metered and you're pretty calm about it, and you're really trying to just emphasize a point, you do really well. And Joe, one of the other positions that, is within, the health systems, and this might springboard us into the who's doing it well, even outside of the chief nursing officer or the chief medical officer, is the chief experience officer. And many health systems are hiring the chief experience officer, who is wholly responsible for that experience and that culture. And they manage all the complaints, and they are the singular point of contact to make sure that consumer perspective, patient perspective, and eventually the care to a degree, outside of nursing and medicine, but that meets the acceptable standards and expectations of the community that they serve.
One of the articles that I sent you this morning that I'm going to send now to Gothic Brina and ask her to post the link on our in our chats is the 30 hospitals that have the best patient experience. And if you're fortunate enough to be around one of these hospitals, I will tell you, it doesn't guarantee that they have a healthy culture.
That's
but
right.
it's really hard to consistently deliver good patient experience if you don't have a healthy culture. Agreed?
Yeah, to be honest, when you sent me that link this morning, I scanned it quickly because I was in a couple of other meetings and took a look, and I thought, oh, this is, this is a little bit of a layup. I can chin the bar and talk about this. I actually read it again a couple of hours ago just to kind of get prepared for this conversation. And two things struck me. Number one, word of mouth is the most powerful marketing tool
Yep.
by far and away. We all ask each other, like, who's your dentist? Who should be my primary care physician? Which emergency department should I go to? Which hospital? Where do I want to get my colonoscopy? We ask those questions of our friends and family. And so word of mouth is absolutely the gold standard for getting good marketing. But that's a direct result. That word of mouth is a direct result of having a good experience at that facility. That includes culture. What was really fascinating about the header in that article is this wasn't like a bunch of formal patient satisfaction surveys that were sent out or around the time of billing and people said, yeah, there's a likelihood to recommend, like, this is fantastic. What that really was AI generated research of 30 million. So it's not like it's a small sample size. 30 million social media posts about hospitals around the country. 30 million. Like, it's 10% roughly of the US population. So it is not a small sample size.
Yeah.
And that was then taken and the data crunched. And that's how those 30 hospitals came up. Like, if you're one of those 30 hospitals, I mean, you should be very proud of yourself, because that is unsolicited, unexpected, and very personal
For sure.
feedback. that people truly took the time to mean, and they meant it deeply to say it's
Yeah.
social media platform.
And I will point out the obvious that when you have a good experience, you may
Right.
tell your friend. If you
Yeah,
have a bad experience, you tell everybody.
that's right.
So, and the fact that they could even identify, uh, 50 hospitals
Yeah.
that got consistently good reviews, that's a bit of a surprise, isn't it?
Right.
You know,
Yeah.
yeah. Mercy Cat points out that bedside nurses are leaving because of short
Mm.
staffing. Nurses are more likely to be assaulted at work than prison guards. Kind of goes along with the other truism about nurses, and that is that they don't retire; they wear out. It's a very physically demanding job, isn't it?
It is. I mean, think about it. For the vast majority of nurses, cerebrally, it's intense because we're constantly having to think about our patients and their clinical care, as well physically for many nurses who particularly work on the floors in hospitals and the units in hospitals. There is all the walking, all the lifting, all the management, all the assisting to and from maybe a bathroom for a patient who has ambulation issues. Like, it is a physically demanding job. And then layer on top of that as well the psychological components of this, whether they work in a high acuity unit or they work in a med surg unit where it may be a little lower acuity. There's still a ton of psychological barrage and tension placed upon that individual, constantly thinking about the welfare of their patients, constantly thinking about the families that they're taking care of, and then potentially even having family members who are not really happy, that are in the room and expressing that and potentially taking
Yeah.
it on them. So it's a really stressful, physically and emotionally stressful position. Again, kind of going back to,
And
we got to take care of them.
for sure. And what you just said really ties in with what Callie Sandy, the RN. Thank you for being a member. But if you can't speak for yourself, bring somebody. Fred, one of the common themes here is that you know I'm one of 7 kids. I have a big I have and my wife is from a big extended family,
Mhm.
but not a lot of them live around me anymore. We all used to live in the same community and we could show up for our parents, our siblings, whoever needed us. And Callie Sandy RN, the reality is that a lot of us are kind of on an island geographically,
Yeah.
not near family or friends. And that's one of the reasons why so much of this conversation is about advocating for yourself. But if you don't have to go into the situation by yourself, I agree with Callie Sandy RN, best to bring somebody with you. And a great point raised by Ruby, and thank you for your super chat. Joint Commission requires maintaining accessible mechanisms for timely consideration of ethical issues. Ethics consults are unknown to patient and family, underutilized by staff. I will tell you that
Mm.
yes, I agree that it was AWOL in Maya's case. I will tell you that my experience with my frustration with ethics consults is it seems like sometimes they're pulled together in hours. Other times they're pulled together in days. And when you're in pain, when you're uh, not getting results, waiting hours, waiting days can
Yeah.
be enormously frustrating. But I do agree that the ethics, the folks who are committed to ethics offer a great opportunity. Again, one more layer of trying to get to the right answers. Um,
Joe, if I could
yes,
go back
feel
2 comments though around advocate, having bringing an advocate or someone to speak for
sure.
you, and then you're kind of teasing out the fact that you are geographically separated. I think one of the things I've seen experienced, and I just want to make sure that your advocates know this, like, not often, but enough still it happens where
Yeah,
some organization will say, oh, due to HIPAA and privacy laws, we can't have you on the phone and we can't discuss this care with you.
yeah,
HIPAA was not designed to be a barrier. HIPAA was
yeah.
designed to be a protective barrier, but not an
Right.
absolute barrier. And so if you hear something like, oh, we can't do it because of HIPAA laws, there are ways to navigate around that and ask them, okay, I know that I can actually participate in my loved one's care remotely. What are the steps that my loved one and I have to take so that you can share this information with me? So I just
Yeah.
want to get that out there, that please don't accept, oh, privacy laws. We can't tell you. That's not.
And the only caveat to that, Fred, is a lot of the folks who say, well, I can't discuss that because of HIPAA,
Yeah.
don't really understand HIPAA, do they?
Right.
Right.
Exactly. That's right.
So if you go down that road, it can be
Mhm.
effective, but you better be ready to teach somebody what the necessary steps are. If you ask the question, you kind of have to know the answer too,
Right.
right?
Mhm.
Yeah,
Right.
yeah. And Martha Ivy, thank you for being a member for a month.
Mm.
Horse welfare. This is the one who asked about the cauda equina before, and she's suffered
Mm.
permanent disability because of that the delayed diagnosis. Now, granted, it's a difficult diagnosis to make, but I think her frustration is that the manager told me she agreed with the physician. It's
Eesh.
tough.
Yeah, it is tough.
Again, I think escalation
Mhm.
the right answer there?
Yeah, escalation is definitely a good answer there. I think one of the other things that it says that story just illuminated, though, was the culture. Because now you've got a physician who just got pitted against a nurse because the nurse decided, for whatever reason, like, hey, that doctor's wrong.
Hmm.
Right? Like, that speaks volumes just in that type of culture, that moment happened for that individual, for her.
Great
In
point.
Yeah, I mean, that's not
Great
the
point.
culture. You need a team culture. And I'm not saying the manager shouldn't say anything, or the manager should just say, "Oh, the doctor's always right." I'm not suggesting that, but I am suggesting that, at least on the contours of the story we were just told, like, it kind of looks like they just pitted each other against each other. Like,
Yeah.
really, is that what you want? Yeah.
Yeah. So let's pivot
Yeah.
to your experiences where culture was done well. You and I met at the advisory board,
Yeah.
which is a think tank consultancy based in Washington, D.C. And I too learned more about culture in my almost 5 years with the advisory board, and really changed a lot for me. I
Yeah.
had never experienced anything
Yeah.
like that. For an example, one of the things that I always pointed out was that we had a lot of very young associates that came straight out of the best colleges and universities in the country. They were
Yeah.
smart and capable and wonderful, and they were hardworking. Um, but we as leaders were
Yeah.
not allowed to send them an email after 5:30 p.m. or on weekends. And if you recall, Mr. Musselwhite would call you on Monday asking why you emailed one of your junior associates on Saturday.
Well, I never
Okay.
got one of those phone calls, so.
Nor did I. Nor did
But
I. Full
but,
disclosure.
but I
But
think but I think what you're illustrating is a deeply embedded culture,
yeah.
and some of it does translate to healthcare, and it's a good segue into the healthcare piece. So, I'm very deliberate, and I continue to carry that to this day,
Yeah.
unless it is an emergency, and I truly, as a firefighter, my definition of emergency might be slightly different than everybody else's. However, that being said, like, if I think about it, if there's an emergency on and we have to work on a weekend, we're all going to know it by the previous Thursday. And we're all going to have to hold hands and realize it's going to happen. But otherwise, I may work on the weekends, but I delay deliver emails so that they drop on Monday morning. And I
Right.
try to be respectful of that. And I try to have that tempo for that very reason. I also don't
Hmm.
block my calendar. I have an open door. I will not just block my calendar uniformly and have you go through my
Yeah.
EA to get time on my calendar. I truly mean my door is open. If you can find
Right.
time, let me know. Just put it on there.
Yep.
I'll accept it. Let's talk. Let's have a
Yeah.
conversation about wherever you sit in the hierarchy, because we're all
Yeah.
colleagues. So I think
And
that is really important.
what made the culture there good wasn't just they would bring in Chick-fil-A.
Yeah.
It was that they gave you protected time to do volunteer work, and they
Mhm.
expected you to do volunteer work,
Mhm.
and they that was just part of the culture. So talk to me about your experience in healthcare where
Mhm.
culture was done right.
Yeah, I think, there are pockets of excellence in my travels over 20 some odd years, as a consultant and advisor to health systems. I don't think I could point to one health system and say you got it right 100% of the time. Um, And I say that without naming names, but I'll use a couple of different health systems. They will remain nameless to protect them all. But I think, the one, even protect them from the fact that they did it so well. I don't want everybody flocking to them. They can't handle the deluge of people coming to their facilities. But I think, one example of doing it really well is I know of an outpatient surgical center, procedural center that here in the Midwest that actually sends home with the individual a handwritten thank you card at the end of the
Wow.
procedure. And it is, and I truly mean it's not stamped, it's handwritten by the actual employees and the anesthesiologist and the physician, as well
Yeah.
as the nursing staff that directly cared for that individual that day. And it says, thank you for allowing us to be part of your care team today and helping you lead a healthy life. And then it's signed by all these folks and it's tucked into the discharge folder. So you see it when you get. I mean, that's a really powerful moment of customer service and truly caring for individuals. I think one of the other ways that you might that any of us might kind of have an inkling that people do things really well and have a good culture at their organization is in that handoff. So if I am walking a patient to a room and as I say, the doctor is running a couple of minutes behind, we're estimating it's probably about 20 more minutes. What can I do for you right now? Can I get you a magazine? What else can I do for you? And oh, by the way, you're in fantastic hands today. I know you have to wait an extra 20 minutes for Joe that you weren't expecting, but Dr. Corcoran, he is an amazing physician. I would go to him if I needed to deliver a baby. So, I'm sorry for the lateness, but
managing up.
You're in fantastic hands.
Yep.
What else can I do for you? And leave it at that. You'll know pretty quickly that you're going to get good care, that you're going to get exceptional quality care. You're going to get good service. So those are some quick indicators along with, you're talking at parties with your friends, like, where do I go for care?
Yeah. But Fred, you just mentioned writing a card and managing up and saying, hey, we're delayed, but what can I do?
Yeah.
Each of those take 30 to 120 seconds to do. And it reminded me of a phrase that one of the hospital CEOs that I don't know if you were on this panel or not, but he talked about them as moments of wow, right? And it's just an opportunity to do something that the patient doesn't necessarily expect. And I don't think anybody in this audience expects to be, treated like a valued customer and, really a VVVIP. And sending a card and, having the conversation that you just previewed, that's treating somebody like a VIP. That's pretty special.
And treating everyone the same way.
Absolutely. And I do want to point out, I was going to make this point earlier when you were talking about, when we had up, I think it was Nancy, talked about hospitals, it's all money driven. I will tell you that I never knew a patient's insurance, whether they were self-pay, whether they were Medicaid, whether they had the best insurance plan, highest reimbursement. And my doctors in my hospitals did not financially screen patients before deciding how they were treated. I would say that the bigger indicator of how you got treated was how you presented yourself. If you were respectful, you were going to be respected back. And you started to kind of tease toward it that, if you approach it with shouting, screaming, anger, that vinegar is probably not going to get you as far as the honey would, or at least water.
Yeah. Well, I think, to the equity piece, it's, I think, so important as a health system leader or former health system leader now. One of the things is I didn't want any of the clinicians to understand insurance or pay or, how is this individual going to pay for it? Because one of the things we do know in the research is that, as long as we found the best practices of clinical care and those are applied to every patient, they're going to have great quality outcomes. And I wouldn't want to infuse whether or not they're going to pay or how they're going to pay or how much they're going to pay into that. And, frankly, who's going to pay and how much is going to pay is a mental set of gymnastics
should not matter.
I'm capable of doing, right? Because it's such a mind scramble right now in the industry. So, it's really about taking care of the person.
For sure. Let me just, so Nancy chimed back in. How do you get doctors to believe you when you can't take a lot of different meds? I have very bad allergies, and I've been told after surgeries I'm a cheap date. So I guess but I think that again, it goes back to how do you establish credibility,
Hmm.
and how do you make sure that your caregivers are paying attention? Any tips for Nancy and the others?
Well, I think she's asking a doctor question. So how do you get the doctors, Joe, to believe you? No, I'll
Yeah.
take it. I'll field it for you. I got this. I think, and it's hard to pick up off of where you just mentioned, because it really is about establishing that credibility and establishing that relationship as the patient. And unfortunately, I'm putting a lot of the onus then on Nancy D here to do this. But it also is an indicator too to Nancy, to you, of how they react and how they handle it, as to the type of culture and the type of physicians and providers that you're interacting with. So it's a little bit of a mixture of both. But yes, there's some
Yeah.
onus on you. But at the end of the day, it's an indicator potentially, if they're not treating you the way you expect to be treated, that might be an indication of the type of clinician they are.
Well, and I would point out that she's talking about following surgeries, right? So the physician is largely ready to walk away,
Exactly.
but I would point out to Nancy that
Mhm.
yes, try to address it with the physician who may or may not hear you. And what I'm reading between the lines of your comment is that you don't always get heard. The reason why I threw it to Fred is because, again, nurses overwhelmingly are advocates for patients. They're very, very good at it. And if the physician didn't hear you because she or he is in too much of a hurry or thinking about the next case, or they're just not listening,
Mhm.
a lot of times the nurse who is helping with your care can advocate for you and say, come up and say, hey, Dr. Fred, you wrote for such and such, and Nancy D doesn't do well with that. Would you consider writing something different? Right. And I will tell you that when that has happened to me, when I was in practice for 17, 18 years,
Mhm.
I never said no to that request.
Yeah.
Right. So again, I think that there is a role for addressing it with the physician who's may actually be typing in the order, but also establish that relationship with your nurse because they're really fantastic advocates.
Look at you. You speak Fred eloquently. That was amazing.
You trained me
Yeah,
well.
that was great. Thanks for the safety net.
You bet, bud. You bet.
That's
So,
it.
any hospitals in your experience that jump out as having really great, or examples of the evidence of really great culture?
Are you asking me to name names right now?
No, no,
Oh,
just
all right.
you can if you want, but
Oh,
you can
okay.
also just talk about by geography or characterizations.
Yeah, it's a grab bag because of the brokenness and the fragmentation of health systems and hospitals generally. And it really is a grab bag. And I couldn't point to one that I would say holistically hits the mark around what typically we call likelihood to recommend, or a net promoter score, that you know
Hmm.
overwhelmingly people would say, yes, I really want to get my care from that physician, that nurse practitioner, that hospital. So we have those scores, and we all get excited about them because we get to be in the top echelon. But if you unpack that a little bit, what you'll find is most likely they're not doing it perfectly everywhere. They're doing it really
Yeah,
well, but they're not doing it perfectly everywhere. And I think most CEOs would admit we still have places that we need to work on within our organization. And for those organizations that are constantly, hungry to continue to change, that's an
yeah,
exciting place to be. But so I wouldn't point that, but I think geography wise, I would say there are a couple here in the Midwest that I know. There are a
yeah,
couple out on the West Coast. I mean, they're scattered throughout the country. There are
yeah.
some actually that are in rural parts of America. There's one out
Hmm.
here in Kansas that there are actually two off the top of my head that I would point to that would say, you know, that's where I would go get my care if I needed
Yeah.
XYZ types of care. because they're so good at it. And that hospital and the people are embedded in the fabric of excellence. So it's not just geographically like urban area. I'm proud of a couple of these Kansas hospitals that I'm aware of that just do a great job.
You know, it's interesting you raised that point. I'm sorry, what was the last
within their
point?
capabilities. I wouldn't suggest like they can do oncology, but within their capabilities.
Right. You know, it's interesting that you brought that up because somebody had asked in one of the questions about, you know, what do you do if your only access to a hospital is a rural hospital? And, you know, I think that in general, most hospitals are good for what I'll refer to as garden variety problems.
Mm-hmm.
But there are also situations where it's worth getting in the car and doing that 2 hour drive.
Mm-hmm.
One of the guests that will be on this program later this month is a 15-year-old girl with scoliosis who went to the local doctor who her plan as proposed by that physician made her uncomfortable.
Mm-hmm.
And she said, but I want to go in a different direction. And she said, well, no, we're going to do this. And well, why? Because I'm the best. That's why, quote unquote, I'm the best. And, you know, my recommendation to the mom was, hey, you know, here are 3 hospitals within a 2 hour drive of your
Mm-hmm.
home. And she went to one of those other hospitals, and it was and had a very different experience. You know, so we will meet that young advocate in the coming weeks. But you know, when I think that there are times when it pays to you know, to go to your local hospital. But then there are times when, you know, going to where they do it a lot
Mm-hmm.
makes a difference, right? And I also want to point out, I think that I have shared this with this audience before, is not everybody in a given specialty specializes in every aspect of that specialty, right? When I was practicing OBGYN, I was much more skilled at minimally invasive surgery than I was at some other types of surgery. And I had partners who did the other stuff really, really well. And so within the practice, we would work together on cases where, hey, I need your expertise on Monday morning, you know, and they'd call me in on Tuesday afternoon, right? So, but it also helps to do your homework about who you're seeing at that hospital
Yeah,
as well.
that's right. I think what you just shared is an example of really good culture and teamwork. We're not experts in everything,
Yeah,
at all, and even to have an individual say, "I'm the best at it," I might question that a little bit because it's kind of like saying I'm an expert in something. I'm not the one who necessarily determines I'm an expert. That
yeah,
my colleagues would be the ones to say, "Fred's an expert
yep,
at this."
yeah,
And this program tonight is a success only because all of your advocates say it's a success, not
exactly,
reasons, right? Like
exactly.
I would question that, but I think kind of to your point, there are reasons to go to your local facility, and there are reasons to go find these folks who potentially do this a lot and have that level
Yeah,
of expertise that you're really looking for. And some of it's procedural, right? Like I'll use colonoscopy as an example. As an advocate myself, I would say, please make
yeah,
sure you get your colonoscopies. It saved my life. Um,
good for you.
but I would say it's procedural, but I also wanted
Yeah,
somebody who had a good personality, not just because he
again,
the most of them. I wanted somebody who did a lot of them and was a nice guy or woman.
again, take care of me, keep me
Yeah.
safe, and if it's not too much trouble, can you be nice to me, right?
Right. Yeah. Yeah.
And that's that, you know, so somebody saying, we're going to do this because I know better, I'm the best, I'm the
Mhm.
expert,
Right.
that's a red flag in my mind,
That's
right?
right.
And Lyrebird is asking, what are the red flags that indicate poor culture? Talks about a bad experience that she had with a C-section.
Yeah.
um,
Yeah. I
so
think
what red flags would you identify?
Yeah, I think we talked a little bit about the green flags, right? Like good handoffs and
Yeah, yeah,
minting up and thank you cards. But there are certainly some red flags. Aside from the fact that a red flag might be as you ask your friends or your loved ones, where should I go for care? And they say, don't go there. I mean, that's an
yeah,
obvious layup of a red flag. But once you're in the facility, excuse me, once you're in the facility and you're interacting with the staff, I mean, people who are on their cell phones sitting behind a desk and can't even take the time to look up at you. individuals who may look at you and say, why are you here again? And all they needed to do was actually look at the screen and maybe even read a few notes, and it might have tipped them off as to why you were here. You know, and then, you know, from a provider standpoint, back to your point around, it doesn't take very long to ask, what else can I do for you? What we also find is it doesn't take too long for a provider to actually sit down in a room during an exam and lower that moment rather than stand up. And just because I'm a sizable guy, and if I come in my fire gear, I'm a pretty opposing human being in a room. But if I can sit down, I can help lower the temperature and lower that moment and make it much more personal. So if the physician or the nurse is standing at the door acting like they need to exit fast, then you might question like the type of culture that's really embedded in there. So those are a couple of quick hit examples. We could go on.
For sure. And I want to. I know that your time is limited. And
I can keep going.
We've gone beyond the hour that I promised you, but I love Christina's question. And Christina, thank you for asking this. Thank you for the super chat. As parents of a daughter with complex health needs, we've weathered more than 20 inpatient hospital stays lasting as long as 52 days. Regrettably, advocating often results in being labeled, and it's also exhausting. And Christina, I think that this is very much what happened with Beata. Beata was definitely labeled when she advocated for a course of therapy for her daughter, Maya, that the hospital was unfamiliar with because they really didn't have anybody that understood CRPS, right? So I totally agree with Christina that advocating can be a double-edged sword. But I will also tell you that if you don't advocate, especially for a young child, that child is going to get lost in the system.
That's right.
So I would advocate. I would suggest that in most cases it's a risk worth taking. But again, goes back to what we were talking about before: vinegar versus honey. And I'm not saying you have to suck up. I'm not saying that you have to be disingenuously pleasant. But understand that you are trying to get people to work with you, not for you, taking care of patients. And so being mutually respectful, I think, is probably the best way to move the care in a direction that you need. Would you agree?
Yeah, I mean, there's not much more to add. Being the parent of a 5-year-old, I mean, I can't think of a much more important thing to do than just be a constant advocate for what I think is right, and model that behavior for my son, that we're going to do what's right. Yeah.
No, 100%. But it is. Listen. It's difficult to advocate for yourself, especially when you're not feeling well. Your kids, with rare exception, are not going to advocate for themselves. So, Christina, God bless you for being there for your daughter. Complex health needs are a challenge. They're exhausting, but you're doing the right thing, and it is a risk worth taking. If you feel that things are going sideways, talk to the care team like you would talk with a member of your family. Hey, listen, maybe we're getting off on the wrong foot. How can we, to use Fred's phrase, how can we lower the temperature? How can we dial it back and work together, help each other do the right thing? Okay. No response. Okay.
Yes, absolutely. I mean, absolutely.
Yeah. So, Fred, I do want to, you mentioned your 5-year-old. I saw a quote earlier, or a comment earlier. I will share that Fred is one of the more eligible bachelors in Kansas City. And everybody loves a firefighter.
Oh, that's right. Oh my gosh.
Fred, it's funny. I think I told you that I can't run any longer, so I started riding a bike. A long time ago, about 15 years ago, and my group would do these 48-mile rides on Sunday mornings, and we would go by one of the firehouses out on the barrier island. And the girls would always yell out, "Hello, firefighters!" Nobody ever does that for your doctor, right?
Yeah, there are some fun videos of like school visit days by the firefighters when they bring the truck. Yeah,
For
yes,
sure.
yes.
Those are days that you always manage to volunteer to be on that day.
It's weird. Yeah, it's the strangest thing. Yeah. My schedule gets freed up just like that. Yes.
Oh my goodness.
Exactly right. Yeah. What I think, I seriously could go on for hours. I always love this. So for the advocates and I think they experience it as well just by the robustness of these conversations. I've been watching the comments fly by, but I can't spend the time, unfortunately, to read them and try to concentrate. But I think part of where I could want to land this plane a little bit is, around, I think I think you've summarized some of this around the advocacy piece and identifying both the red and the green flags, but, also kind of circling back to one of the things that we talked about a little earlier on in the conversation, which is around, it starts inside healthcare and it starts with ourselves as clinicians who change the culture of healthcare. Like, we are going to depend on a lot of folks, including all the advocates on the phone or on the podcast. But at the end of the day, it starts with each one of us remodeling the behaviors that we're expecting of one another. And it can start from the top. Theoretically, it could start from the bottom, but it does start from the top. And it also just starts with each one of us moving forward. So, it's just really important, and we've got to get it right. There's a book that John Nance wrote that's called Why Hospitals Should Fly. I don't know if you've read it or not. It's a quick.
I absolutely have read that book.
A quick, easy read for anyone. It's a series of stories or vignettes around, and it just draws the parallels to the aviation industry. And while we could spend hours, dissecting the differences between the aviation industry and healthcare, there are some real parallels because it's all about safety and the culture of safety. And the culture that's embedded to drive that safety aspect. And it's a good read to talk about how we've got to come along and adapt. And we are probably, I would argue, one of the slower, if not the slowest industries to start to adopt those types of practices and that way of thinking in those behaviors to drive those outcomes.
Yeah. And Fred, I totally agree with you that we could go on for hours and hours about this. Unfortunately, I know that you've got
I hope you invite me back. We'll do it again. Yeah.
Well, I am hoping that I can get you back. I would very much like to continue this conversation. I previewed last weekend that we were going to have this conversation, but I also said that it was the beginning of a conversation to help build stronger advocates in this group, right? So I would very much like to have you back and go a little deeper, maybe go into some different rabbit holes than we went down today. But any comments that you'd like to make before I let you get back to being a dad?
Well, I mean, obviously, thank you, Joe, first to you, and second to all the advocates who hung around for an hour and 30 minutes. I most appreciate it. And I think, if I get the honor to come back and be a part of these discussions in the future, I'd love to hear from the rest of your advocates as well. What might be interesting to them in these topics around culture and practice and healthcare, and maybe I can come back and maybe they take a straw poll. Do we even want Fred back? So we'll see. I'd be remiss if I didn't try to land the plane here in our final moments with kind of a go Chiefs. So I think we're going to have an exciting Sunday evening for everybody here that might be a football fan.
The idea that the Chiefs are the underdogs is mind-boggling, but I will also point out one of the comments that you may or may not have seen from Patty P. Aviation is a bad comparison these days. Don't sit by the door.
Right. Probably a little too soon. Okay. I think they're still licking their wounds from that. Yeah.
Agreed. But a follow-up from Callie Sandy RN. Frank, Fred, thank you for all you do. I've got great ideas from this talk, and thank you to Dr. Joe too. This is how to start a positive change. And Callie Sandy, that's what we're here for.
Yeah.
That is, we all came together, Fred. This community developed out of the Take Care of Maya trial, but we're really pivoting, and 24 is really going to be a big boost for this, as we are really pulling together to make an impact, to make a difference. The Maya trial has come and gone, for better or for worse. We will never find a way to bring Beata back and reunite that family. But if we can be a part of the movement that prevents another Kowalski tragedy to happen to a different family, well, that would be a giant win. And again, as I shared with you before the program, there are so many people like Purple Pros have children with rare syndromes and find it difficult to be advocates. Christina, again, often the issue lies in communication breakdowns among various teams. And I will tell you that the transfer of information at shift changes, I will tell you that I've gotten grief from care teams when I inserted myself into those handoffs, right? But I fully encourage every member, particularly every member of this audience, particularly when you are there as an advocate for a loved one, whether it's your child or your parent or your spouse or your partner or whomever, abso-freaking-lutely stand up, walk over, listen, and if there's something that they're not getting right, offer it, right? You have your set of information that you know very, very well. They have their skills and their set of information that they know very well. Together, that's pretty darn powerful.
That's a strong culture with a high-performing team. And we can take lessons from a whole host of industries, as well as the 49ers and the Chiefs.
You had to go back.
In jest, but truly, like, that is the illustration of a high-performing team, is that they complement each other and they work together, and they, not only respect each other, but they operate as a single unit, even though it's multiple people. Yeah.
Absolutely agree. Absolutely agree. Fred, you have been a spectacular guest. I hope that we can get you back on here soon. I will, despite what's her name with the red lipstick, I will be cheering for the Chiefs this weekend. What's her name? She's kind of famous.
Well, she's altered the center of gravity and moved it to Kansas City. So we thank her for that. So
undoubtedly. I mean, you talk about New York and LA is just being blown off. It's all about Kansas City when Taylor's involved. So Fred, thank you so much for being a part of this. Thank you for sharing your insights and your experience, and can't wait to bring you back, my friend.
I'm looking forward to it. You won't have to try hard. This was a lot of fun. So thank you, everybody.
Outstanding. Thank you, Fred. Take care. He's an amazing guy, and as real as they get. He is wicked smart, but as down to earth and grounded and ton of common sense. I would want him advocating for me if, heaven forbid, I were a situation where I couldn't advocate for myself. Terrific guy. Man, you all brought the heat tonight. You were asking some really good questions, both prior to and during the program. Thank you so much. It was interesting. We got a question from somebody in the chat. The very first post in response to the community ask about what do you want to ask Fred. The very first post, where is it? I can find this. Sparkle Plenty. This is new to me. Please explain. Maybe other hosts don't solicit questions, areas of interest from the audience. Listen, I've told you from the beginning, I want this to be a channel that brings you information that you want to know about. So I'm going to continue to do this. I've done it for the last two programs with Nick, Whitney, and today with Fred. I'll do it again next week. I will tell you that next week on Monday, I will be bringing you hopefully a different side of Paul Langell, juror number one, to the wider world. Um, I'm really doing my best not to call him that, because having met him and having sat with him for an hour, I will tell you that there is so much more to that guy. And his wife, hippo lover, um, Yoli, is they're just a neat couple. They've been together 7 or 8 years, and they love each other, and they have a very cool relationship. So hopefully I can bring you a different side of him. I don't know if Yoli's going to join us, but if she does, then hopefully I'll bring you a different side of them. And then not 100% about Thursday, but I'll put that up over the weekend. Let you know who's going to be coming. And again, if you will continue to submit questions, I'll continue to ask for them. Uh, uh, Sally, Tuco Limited, just call him the number one Paul. You're absolutely right, Sally. Well said. Well said. And Sally, thank you for joining us from the UK, by the way. Anyway, listen, as I said, you guys really brought the heat. You brought great questions. I know that we didn't answer every question. We didn't even scratch the surface on a lot of questions. But as I've been saying all along, this is going to be a series of conversations that hopefully we build, and over time, not years, but weeks and months, hopefully we can build the foundation that you need to be a better advocate for yourself, for your kids, for your parents, for your partner, for your spouse, for your loved ones, for your neighbors, right? Again, the geography. Again, one of 7 kids, and three of us live in Florida, but in all different places. And I've got family in 3 of the 4 time zones. When I was working out in California and Nevada, we actually had all 4 time zones covered, right? So we're separated. We're distant, and so we need to be able to be there for one another. And again, it's also, somebody mentioned it before: see one, do one, teach one. So if you can help others learn how to advocate, listen, I would love for them, I'd love for you to bring them into our community so they can be a part of the conversation. I appreciate the fact that there are, so many folks that have given thumbs up and liked this. I love that there are so many folks that have, that have been, who have become subscribers to this. We still are about 29 subscribers away from hitting that 11,000. I really hope you can help me get to 11,000. But you know, uh, eh, hopefully we can be the teachers that teach the others, right? So this will be a series of conversations, and over the next couple of weeks and months, I'm going to probably go back and forth, not left, right, but we will have several conversations that are still very trial related. And then I'm hoping to bring you more and more conversations that are like tonight, about maybe some of the things that were the bigger themes that came out during the trial, that help make us better going forward. And again, reduce the likelihood that the tragedy that befell the Kowalski family ever happens to anybody in this community or anybody in your communities near your home. That's what we're really aiming for. So I just want to say thank you so much for being a part of this. Thank you so much for those of you who are subscribers, those of you who hit the like button, those of you who share this. I love having so many members who have joined the community. We will be doing a members only in February as well, by the way. Um, and also to everyone who participates in the chats, everyone who participates in the comments. I always watch the episodes the next day, and I really do more reading of the comments and trying to get a sense of what is it that you're saying and that you're interested in? Because again, I want the content that we cover to reflect what your interests are. So, with that, I'm going to sign off for the night. Wonderful having Fred join us for for the evening. I hope that you enjoyed it, and I hope that we get to have him back soon. But for now, we're going to call it a night. And I just want to remind you, take care of yourself so that you can take care of others. Um, Thank you for being a part of this, and look forward to getting us together again soon. Thanks so much.